Hello guys, welcome everyone to Physics Wala Method. I am your faculty for medicine, Dr. Santosh, and here we are continuing our Read Harrison series. So today we will be talking about neuropathies. Don't worry guys, the stroke part 2 is on the way. The schedule will be shared soon. Okay. So here we will be addressing neuropathies. So we'll begin by defining what are neuropathies. Okay, just give me a thumbs up if you're able to see me live. Okay, cool. Okay, so I will start with Bashir Explorer. Welcome. So we'll start with definition of the neuropathies. What are neuropathies? Okay, so this is the standard definition that you will find in most of the textbooks. Neuropathies are disorder in which there is inflammation or degeneration of peripheral or cranial nerves. So remember, the peripheral nerves and cranial nerves together form what we call as peripheral nervous system, right? We call it as PNS or peripheral nervous system. Good evening, everyone. Good evening. So disorders which cause inflammation of the neurons in the peripheral nervous system. That means peripheral nerves or the cranial nerves, resulting in impairment of their conductivity. The function of the neurons is to conduct the impulse from one location to the other. But if there is either inflammation or degeneration, then there is impairment of the conduction, and this condition is what exactly we call as neuropathies. Now what will happen if the peripheral nerves or the cranial nerves lose their ability to conduct? What is the outcome? Obviously outcome depends on the function of those individual neurons. Now whenever we talk about peripheral nerves, we know that peripheral nerves contain three important components, right? Peripheral nerve components. What are those? The first one is motor neurons, right? Peripheral nerves contain motor neurons, which are carrying the signal from the spinal cord to the neuromuscular junction. Then peripheral nerves also contain sensory neurons, which are carrying the information from the sensory receptors in your skin to the spinal cord, eventually to the brain. So sensory neurons, and they also contain autonomic neurons, which are concerned with the regulation of sweating, vasomotor tone, and other functions. So these are the three components of our peripheral neurons in the peripheral nervous system, right? Now, whenever I lose functions of these neurons, obviously impairment will result. So what clinical features I can expect? Now you should tell me what kind of motor neuron we have in peripheral nerve. Do we have upper motor neuron or lower motor neurons? Good evening, everyone. Good evening. So what kind of motor neurons we have? See, we know that there are two motor neurons. One that starts in the motor area of the brain, the frontal lobe motor area. From there, it descends through the subcortex, brainstem, lower end of the medulla, decussate to the opposite side, descends down through the spinal cord till its destination is reached in the spinal cord. This neuron we call it as upper motor neuron. Once it reaches the destination in the spinal cord, this neuron moves into the spinal cord and synapses with the next order neuron. The cell body of the next order neuron we call it as anterior horn cell, and from there the next neuron moves all the way to neuromuscular junction, and this is what we call as lower motor neuron. So which kind of motor neuron we have? Right, so we have the lower motor neuron. In the peripheral nerves we have lower motor neurons. So when these lower motor neurons are damaged, what symptoms I can expect? When I need to do voluntary movements, right? I need to grab something, I need to make movements. Whatever signal my brain sends will not be able to reach the muscles because the lower motor neuron is damaged. So the muscles will not be able to execute voluntary movements. And this is what we call as weakness of the affected group of muscles. And earlier, when we have started discussing the neurology, we have clearly understood that longer the journey of a neuron, it is more likely to get affected when it comes to peripheral nerve disorders. So obviously, the distal most part are the ones which are having the longer journey of the neurons reaching them. So the weakness will predominantly affect distal group of muscles more than proximal group of muscles. Okay, and in these patients, when we examine the deep tendon reflexes and tone, what will happen? The lower motor neuron is responsible for maintenance of tone and is part of the reflex arc. So when the lower motor neurons are damaged, we will lose the reflex arc and the deep tendon reflex will come down. and it is responsible for maintenance of the tone. If it is not functioning, the tone will come down. So as I think all of you clearly know it now, the tone and deep tendon reflexes will be diminished. So when tone is diminished, what do we call it as? We can either call it as hypotonia, or we can also call it as flaccidity, because the muscles have become flaccid. They are not stiff anymore, right? And when tone is decreased, what we call it as? Hyporeflexia. And if it is totally absent, you can also call it as areflexia. Clear? So once that, patients will develop distal weakness, right? Weakness of hands resulting in grip weakness, repeatedly dropping objects, weakness of the small muscles in the feet resulting in not able to hold the slippers properly, foot drop, right? All those things. Then we have these sensory neurons. So when sensory neurons get affected, what will happen? We can lose the sensations carried by those neurons. And here also it is length dependent involvement. So we will have distal sensory loss. Okay. But whenever you see a patient with peripheral neuropathies, more than loss of sensations, what complaint brings them to the hospital? It is the presence of pain or some tingling numbness. They come to the hospital saying that some tingling numbness or pain is there in my hands and feet. That is the usual presentation, right? So that is why the symptoms of sensory neurons, neuron damage, we can divide into two groups of symptoms. One is called as positive phenomena, and the other one is called as negative phenomena. Now, what is this negative phenomenon? Whatever normal function that your sensory neurons are supposed to do, they are not able to do it. And that results in certain symptoms like touch, I should be able to feel, pain, I should be able to feel, temperature, I should be able to feel, but now I'm not able to feel them because my sensory neurons are dysfunctional. So these symptoms will come under negative phenomenon, right? Negative phenomenon basically means loss of sensations, loss of sensations. But apart from that, the neurons which are getting degenerated often start incessantly firing their neurotransmitters, resulting in passing false signals to the brain. So sometimes, even without any stimulus, these patients experience tingling sensations, or they feel like someone is pricking them with the pins or needles, or even pain or burning sensation. So these symptoms normally without stimulus should not happen, right? If I don't touch you with a hot object, you should not feel the temperature. If I don't give you a painful stimulus, you shouldn't be feeling the pain. But these patients are feeling the pain in the absence of the stimulus. So such symptoms we call it as positive phenomenon. So under this, most important thing you need to remember is pins and needles sensation, usually described as pins and needles sensation, then burning sensation, and perceiving pain. These are additional symptoms that we should be aware about. And when it comes to involvement of autonomic neurons, what symptoms it will lead to? We have called it as pseudomotor symptoms. And then patient will often have the sweaty palms, sweaty feet. There will be hair and nail changes, right? Hair and nail changes, because there is loss of vasomotor regulation. So reduced blood supply to the distal part, resulting in reduced blood supply to ever growing, rapidly growing tissues like hairs and nail. So we will lose them. So these are the symptoms we can anticipate whenever a patient has peripheral nerve disorders. So with this background, Sutapa, see, normally when a peripheral nerve gets damaged, if we have damaged the sensory neurons in that nerve, obviously its function is gone, right? Because it is not able to conduct the information coming from the sensory receptors. So we have lost the sensation. Ideally, we should perceive, but we no longer perceive it. So we call it as negative phenomenon. But these neurons, which like, let me give you an example. Let me say that this is one neuron which is picking some information from the sensory receptor. So think that this is a receptor, and from here it is picking the information, and then it is passing on that information to the next neuron. Okay, it will pick and pass on that information to next neuron. But what I have done here is I have caused some damage to this neuron. Okay, so now from this receptor, it will not be able to send the sensation to the brain. We have lost the sensations. But after cutting this damaged neuron, whatever neurotransmitter it has, it starts unnecessarily releasing it. We often call it as cry of dying neurons. The neurons damaged, they start releasing their neurotransmitters. So if it releases the neurotransmitter, what the next neuron will think? Okay, I'm getting a pain signal, I'm getting a injury signal, or I'm getting a burning signal, and that signal will be passed on to brain. So now the brain start thinking that okay, in the feet or palms there is burning happening, or there is pain happening, or there is pricking happening, and these symptoms will bother the patients. Now, these symptoms are happening without any stimulus being given to the patient. That's why we call it as positive phenomenon. Means ideally we shouldn't feel these symptoms without stimulus, but we are feeling it without stimulus. So we're calling it as an addition or a positive symptom. Okay. Now, Nilanjana, yeah, it is being scheduled, so it will be part of the next week. We will continue there. So, having understood the basics of neuropathies, most important thing that is asked to undergraduate students is how do you classify different types of neuropathies? Okay, so there are three ways we can classify neuropathies. First one is based on the number and distribution of nerves affected, whether only one nerve is affected, multiple nerves are affected. The second one is based on the types of neurons involved. Means neuropathy need not always mean that all the three components of the peripheral nerve are affected. Means it may not affect the motor, sensory, and autonomic neurons together. It may only be affecting motor neurons, only be affecting sensory neurons, or a mix of these, or only be affecting the autonomic neurons. So based on the type of neurons affected, we can also classify the neuropathies. And third one is based on the pathology affecting the nerves, like whether I'm causing the demyelination or whether I'm causing the neural injury, right? So first we will focus on based on the number and distribution of the nerves affected. If only one peripheral nerve is affected, then we will call it as mononeuropathy. Mononeuropathy. Like for example, only radial nerve is damaged, only ulnar nerve is damaged, only third cranial nerve is damaged. We call it as mononeuropathy. Right? Single nerve affected. Then we will call it as mononeuropathies. Okay. Obviously, the symptoms will depend on the function of that nerve, right? You know, what are the muscles supplied by radial nerve, what are the muscles supplied by ulnar nerve. So if I damage ulnar nerve, muscle supplied by the ulnar nerve will go dysfunctional. Then, to give you an example, you know, diabetes, right? In diabetes, because of the increased production of glycated end products, there is damage to the neurons. Now, in diabetes, there need not always be a selective damage to one nerve. Diffusely, all the nerves will get damaged. Such condition we call it as polyneuropathies. Polyneuropathies. Can anybody give me another polyneuropathy example other than diabetes, which we have already discussed? Multiple or all nerves diffusely affected. Means there is no selective involvement of only few nerves or one nerve. Diffusely affected. Multiple sclerosis is not a neuropathy, right? Multiple sclerosis is a demyelination of the central nervous system. When we say neuropathy, we are referring to disorders affecting the peripheral nerves or peripheral nervous system. Right? You remember GB syndrome? GB syndrome is nothing but a polyneuropathy disorder. If you go back and look at the way we have defined it, we have defined it as polyneuropathy. Right? So examples for the polyneuropathy are diabetes mellitus causing neuropathy and your GB syndrome, where all the nerves are diffusely affected. Now there is a third entity called as mononeuritis multiplex. Mononeuritis multiplex. Now what do I mean by this? See, in GB syndrome, all the nerves are diffusely involved. If I have some damage to my brachial plexus, I may be selectively causing only damage to one particular nerve, right? Radial, axillary, or something like that. But if multiple nerves discretely, not part of a generalized process, like okay, I have a third cranial nerve palsy, okay, then I also have a radial nerve palsy. Then there is more than one nerve involved, and it is not part of a generalized process. Not all the nerves are being affected. So such condition we call it as mononeuritis multiplex. In simple words, mononeuritis multiplex is nothing but multiple mononeuropathy. Multiple nerves individually being affected. Multiple mononeuropathies. We call it as mononeuritis multiplex. Like third cranial nerve plus radial or ulnar. Yes, in leprosy, often we get mononeuritis multiplex. Mononeuritis multiplex. Okay, so this is one way of classification based on the number of cranial nerves involved. Yes, in amyloidosis, you can get polyneuropathy as well as mononeuritis multiplex. But leprosy is a very classical example that I can quote. Rarely we get polyneuropathy. Most often we get mononeuritis multiplex. Okay. Another way of classification is based on the types of neurons affected. So it can be motor neuropathies when only motor neurons are affected, or it can be sensory neuropathy when only sensory neurons affected, sensory neuropathies when only sensory neurons are affected, or it can be both involvement of motor as well as sensory. So in that case, we call it as sensory motor neuropathies. Sensory motor neuropathies. Okay. Now there are a few MCQ points here. The first one, in terms of based on the number of nerves affected, polyneuropathy is the most common type. And in terms of the nature of neurons affected, it is the sensory motor neuropathies, which is the most common type. So majority of the neuropathies you see, there is involvement of both the sensory neurons as well as motor neurons. Only few inherited disorders, you may have predominant motor involvement or predominant sensory involvement. Okay. Then third type of classification is based on the pathology affecting the nerves. Okay. So here we have demyelination. Demyelination, that is one type, and the second one is axonal injury type. More on this we have already discussed in the GB syndrome, how to identify demyelination and axonal neuropathy based on the nerve conduction study, so you can look back at that. And the third one is where axonal degeneration as well as demyelinations happen, we will call it as mixed type. So this is the basic classification of neuropathies. So from classification of neuropathies, we will get into what are the common causes for neuropathies. The causes for disorders affecting the peripheral nerve can be divided into two groups: inherited conditions and mostly MCQs are centered around only two topics. One, there is a specific subtype of inherited neuropathies called as Charcot-Marie-Tooth disease, and the diabetes mellitus and related complications, including neuropathies. Okay. So first we will look at the acquired causes for neuropathies. First MCQ point is, what is the most common cause for neuropathies? The most common cause for neuropathies is diabetes mellitus. Diabetes mellitus. Okay. Apart from diabetes mellitus, nutritional deficiencies can also cause neuropathies. And when it comes to nutritional deficiencies, remember it is mainly the B complex group of vitamins deficiencies are known to cause neuropathies. Particularly B12 is such a common condition in India responsible for neuropathy. So among them, the most common deficiency responsible for neuropathies in India is B12, because a larger number of Indians are vegetarians. And the second reason is there is a high prevalence of pernicious anemia in India with anti-intrinsic factor antibodies. And because of that, even if you are non-vegetarian, your absorption of B12 may be poor, and we end up resulting in the peripheral neuropathy. Okay. Then drugs are known to cause. Sohail Makbul, this will be scheduled in the coming week sessions. We will be covering that. Yeah. Okay. So drugs are also known to cause the peripheral neuropathies. Because the schedule is prepared quite ahead of time, making changes becomes a bit difficult. Apologies for that, but we will cover that. We will cover that for sure. Okay. So when it comes to drugs, I want you to remember at least two drugs. First one is INH. I think all of you know about it. Whenever you think of INH, it comes to your mind. But apart from that, metronidazole being used left, right, center nowadays by various doctors for whatever indications is also emerging as an important cause for causing the neuropathies. Okay. Then infections cause neuropathies. And I think already one of you have mentioned leprosy is a well-known infection to cause neuropathy. Apart from that, polio. Remember, what is polio? The polio is also usually called as poliomyelitis, right? Poliomyelitis. Now, the term myel primarily refers to spinal cord. So, polio is a disorder where virus is neuropathic and it predominantly targets a specific cell called as anterior horn cell. Anterior horn cell. Now, where do we find these anterior horn cells? We find them in the gray matter of the spinal cord, anterior horn of the gray matter of the spinal cord. and that is where the lower motor neurons journey begins. So poliomyelitis is primarily a lower motor neuron disease affecting anterior cells and the course of the nerves. That is why it is a disorder affecting peripheral nerves too. Okay, so apart from that, polio is also something that you can quote under infections causing neuropathies. Okay, then plenty of toxins are known to cause neuropathies, but the one that you should remember is lead, because when in forensic medicine you study about lead toxicity, emphasis will be on what it does to your blood and what it does to your neurons. It causes neuropathy. Okay, and then the last acquired cause is compressive neuropathies, where your nerves are getting compressed, like your Erb's palsy, Klumpke's palsy. They're all compressive neuropathies. Because of the compression, there is inflammation of the nerves and they're losing the function. So these are all acquired causes. MCQ wise, I want you to remember what is the most common cause. It is the diabetes mellitus. Second most common cause in India is B12 deficiency. Okay. Now coming to the inherited causes. Inherited causes, atropine does not cause the neuropathy. See, what is atropine? What is its essential function? So Todd's palsy is a muscle disorder. It is a muscle dysfunction. See, what is Todd's palsy? After your seizures, you're not able to contract the muscles. You have lost the power. Why that happens? Because during seizures, your brain is sending uncontrollably sending signals to the muscles. So neuromuscular junction are sending all those acetylcholine to the muscle. Muscle gets hyperstimulated, contracts vigorously. So during contraction, it is using up all the energy reserve, the glycogen, ATPs, everything is used up. Now, once the seizure is over, the muscles do not have sufficient ATP reserve to be able to contract. So for next few minutes to few hours, the patient will remain extremely weak or paralyzed. Once the muscles resynthesize sufficient amount of ATPs, you will be able to start contracting. So where is the problem? The problem is in the muscle, not the nerve. So Todd's palsy, we will not count it as a neuropathy. Right, it is an anticholinergic drug. So where is the choline, acetylcholine playing the role in the neuromuscular junction? So we won't count that atropine toxicity. We won't count it as a peripheral nerve disorder. Okay. Now, the inherited causes for the neuropathies, they will be further classified into three groups based on the type of nerve effect. We are inheriting. Obviously, there will be genetic reasons. We will have some mutations, and those mutations will be responsible for impaired functioning of the neurons. The first and the most common type is hereditary sensory motor neuropathy. This is the most common type. And among the hereditary sensory motor neuropathies, when I say sensory motor means these are the patients where they will have sensory neurons also getting damaged and the motor neurons also getting damaged. The Charcot-Marie-Tooth disease accounts for majority of the cases. Charcot-Marie-Tooth disease, and this is a topic that MCQs are frequently asked these days. Charcot-Marie-Tooth disease. Okay. Then hereditary sensory and autonomic neuropathies. Now these are the patients where the sensory neurons and autonomic neurons are damaged, but not the motor neurons. And third one, hereditary motor neuropathies, purely affecting the motor neurons only. Okay. Now my question is, if I get a patient with neuropathy, if it is mononeuropathy, most commonly mononeuropathies are caused by compressions or some localized infections, or the surgical trauma during surgeries, like the recurrent laryngeal nerve being damaged. But when I have mononeuritis multiplex or polyneuropathies, how will I get to know whether this particular patient has an acquired cause or inherited cause? So please remember, guys, most of the inherited causes for neuropathy, they present in early childhood or early adulthood. So if I see someone presenting with neuropathy now in their 40s or 50s, it is unlikely to be inherited. It will almost always be acquired. But if I see a 5-year-old, 6-year-old, or a teenager presenting with neuropathies, there's every possibility that it may be acquired, but I should also consider the possibility of inherited disorders, right? Okay, so we will focus on what is important for us from the exam perspective, that is Charcot-Marie-Tooth disease. Two possibilities here. One, MCQs are possible, and sometimes for a 3 mark or 5 mark, they will ask you to write few points about Charcot-Marie-Tooth disease. So Charcot-Marie-Tooth disease is the most common cause for inherited neuropathies. Inherited neuropathies. And this is also a hereditary form where there is involvement of sensory as well as motor neurons. Sensory and motor neuropathies. And these patients usually present in childhood to early adulthood. Early adulthood. Okay. Now, in terms of MCQs, what they will ask you? They will ask you what is the most common, because we have made a long list of subtypes of Charcot-Marie-Tooth disease. Or in simple words, like anyone who presented with sensory plus motor neuropathy, which is inherited in nature, we label it as Charcot-Marie-Tooth disease. As we go on discovering new and new mutations, we go on giving them new numbers like CMT1, 2, 3, 4. The list goes on. You mainly have to remember CMT1 and CMT. Okay. Now, in terms of MCQ, what they will ask you is what is the most common type of Charcot-Marie-Tooth disease? The most common type is type 1. Type 1 is the most common type, which accounts for 70% of all cases. 70% of all cases of Charcot-Marie-Tooth disease. And here they will also ask what is the mutation responsible. There is the only mutation you need to remember, that is PMP22. That is the only mutation that you need to remember. Okay. All others, you don't need to remember the mutations or anything more. It's not expected from an undergraduate student. Now, what else you need to know about the Charcot-Marie-Tooth disease? Their inheritance pattern. So they can be inherited in various patterns depending on which type it is. They can be inherited as autosomal dominant, autosomal recessive, as well as X-linked. Okay. Now, among the four commonest, I want you to remember that the CMT1, 2, 3, right? These are autosomal dominant, and CMT4 is autosomal recessive inheritance. So this can be a potential MCQ. Which of the following Charcot-Marie-Tooth disease is inherited as an autosomal recessive condition? The first, second, third are autosomal dominant, and the fourth one is autosomal recessive. For the first, they also ask you about the mutation, so please remember it. Okay. Now, if I get a clinically oriented question, what should make me suspect that I am dealing with a case of Charcot-Marie-Tooth disease? Because they may give you a story, right? This is a child or a teenager presented with these symptoms. Okay. And then they will ask you, mutation in which of the following genes is likely to be expected in these patients? So please remember, in the early childhood or at max early adulthood, these patients start presenting with symptoms. Now, what symptoms I'm expecting? It is a polyneuropathy condition, right? And in polyneuropathy conditions, the distalmost group of muscles are earliest to be affected. So hand and feet, and that too feet first, because more than hands, feet have the longest journey of neurons. Okay. So when small muscles of your feet become dysfunctional, right? What symptoms you will expect? Patient will have difficulty to clip on to the slippers, so there will be slipping of slippers. They may develop foot drop. But please remember, we are talking about children, so that is the developmental age, right? So they are learning to walk, they are learning to run, learning to stand on their feet. During this phase, if the feet muscles are weak, it can lead to some anatomical defects, right? What is anatomical defect I can expect? What is the defect that you see in this image? What is the defect that we are seeing in this image? Nilanjana, absolutely right. Yes, we can have hammer toe, high arch, right? What do we call that high arch? We call it as pes cavus, right? Pes cavus deformity. Okay. And then atrophy of the distal group, like feet muscles and distal muscles of the leg, sparing the proximal muscles, may make it look like a champagne bottle. So this finding is called as inverse champagne bottle sign. Champagne bottle sign. So whenever a question says that a child has developed the pes cavus defect, or they give the image of this leg, which when you see it looks like an inverted champagne bottle, then you're probably dealing with a Charcot-Marie-Tooth disease. And among them, we know that the most common is type 1. So if they're asking which mutation we would expect, it is most likely PMP22. Okay. Now, having understood little bit about Charcot-Marie-Tooth disease, with this we will be able to write 3 to 4 marks points and MCQs can be addressed. Now, let us move forward. So the next thing that we need to know is if I'm suspecting that a particular individual has peripheral neuropathy, how will I take it to diagnosis now? Clinically, I have suspected because there is distal weakness, distal sensory loss, pseudomotor features, atrophy, diminished deep tendon reflexes, diminished tone of the affected group of muscles. So I'm suspecting that it is probably a peripheral nerve disorder. How will I confirm the diagnosis? Niranjana, there were three people who initially described this condition. So their names are Charcot, Mary, and Tooth. Okay. So what is the investigation of choice? What all investigations I can do? See, there are two things. One, पहले neuropathy confirm करना है और फिर उसके underlying cause को investigate करना है. So if I see someone in their 40s now presenting with neuropathy, I will think of diabetes. तो पहले क्या करूँगा? एक neuropathy confirm करूँगा, फिर diabetes के लिए HbA1c, MBBS, PPBS या CGM जो भी investigation जरूरी है वो करूँगा. Right? But neuropathy कैसे confirm करना है? That's the first step. Because I may be misdiagnosing some other disorder as neuropathy, right? So what is the investigation of choice? And what other investigations we can do? The investigation of choice is your neuroconduction study. Because neuroconduction study not only confirms that you have neuropathy, it will also tell you whether it is sensory or motor, and it will also tell you whether it is demyelinating type of neuropathy or whether it is axonal injury type or whether it is a मिक्सड इंजुरी. ये आगे जाके आपको अंडरलाइन कॉज इन्वेस्टिगेट करने में आसान करती है, राइट? सो द इन्वेस्टिगेशन ऑफ चॉइस इज नर्व कंडक्शन स्टडीज. Nerve conduction studies where we can look at the compound muscle action potential as well as the conduction velocity. What other investigations we can do? We can do the peripheral nerve biopsies. Biopsy also we can see whether there is demyelination happening or axonal injury degeneration happening. That is another investigation that we can do. Particularly in which set of disorders we think of doing a peripheral nerve biopsy? Most cases for neuropathies, it is the nerve conduction study which is sufficient, but in some set of disorders, we might have to consider peripheral nerve biopsy. Right. Mainly in India, we do peripheral nerve biopsies for a suspected case of leprosy. Right. Which nerve is the preferred site? Which nerve is preferred when we are suspecting leprosy and we need to take the biopsy? That is an MCQ that they ask from dermatology. So remember, it is the sural nerve biopsy, because when you need to do a nerve biopsy, you need to pick it up from the most superficial part, right? Which is like you don't need to cut through multiple fascia and reach a deeper nerve. Something which is very superficial, accessible, and if I cause some damage, less damage is expected. If I am not able, if I cut the nerve completely, less damage is expected. That is why sural nerve is preferred. Okay. Now, look at this image and tell me what is this used for. Ideally, we diagnose a peripheral nerve disorder with nerve conduction study. That is the investigation of choice. Now, what is this used for? Is it used for diagnosis of peripheral neuropathies or something else? Okay, I'll show you what is it. You can see a small tube which is anchoring a filament or a thread. Okay, and this person is applying pressure with this thread or a filament on the patient's feet. What is this called as? And what is it used for? 2 points to address. So the instrument that you see here is called as Semmes-Weinstein monofilament. This Semmes-Weinstein monofilament is also known as 10-gram monofilament. What is it used for? Okay, see, socho ki you have a diabetic patient who has now got peripheral neuropathy. Now, because of peripheral neuropathy, he has lost a little bit of sensations and he is also experiencing some positive phenomenon like pins and needle sensations or burning sensation. Ab ye burning sensation and pins and needle sensation is something that really bothers the patient. It literally takes away his sleep. वो आके आपको कंप्लेन करेगा कि हाथ में पैर में जलन होता है, कुछ चुभे जैसा लगता है, रात में सो नहीं पा रहा हूँ. So there are various medications we can use like gabapentin, pregabalin, And once we start those medications, right, this pins and needle sensation reasonably improve and he starts getting a decent enough sleep. A patient का problem solve हो गया. But as a doctor, I'm even more worried for peripheral nerve disorder patients. Why? Because they have lost the sensations. So as time progresses, they will go on losing the sensations, and the sensations are our protectors, right? When trauma happens, we feel it. So we protect ourselves and we recognize the trauma and treat it. अब जो sensation चला गया है, so when these patients suffer multiple micro traumas, they don't identify it, they don't feel it. So trauma होते होते जाता है, and then eventually some part of the foot there will be an ulcer which they have not recognized. Now the ulcer gets infected, it goes on propagating, it becomes a mess. This is what now we start calling it as diabetic foot. Eventually काटना पड़ता है, right? Amputations it can lead to. तो अब मुझे जिसको मैंने पेरिफेरल नर्व डिसऑर्डर के नाम पे डायग्नोज किया है उसे एम्पुटेशन तक पहुंचने से रोकना है, राइट? सो हाउ कैन आई डू दैट? यस, अंडरलाइंग डिसीज को ट्रीट करेंगे, बट अपार्ट फ्रॉम दैट how can I recognize that this particular individual is at risk of developing trauma resulting in an amputation? So this test is not used for diagnosis of neuropathies. It is used for detection of something called as lobs. It is used for detection of lobs. Now what is this lobs? I will tell you. Lobs refers to loss of protective sensations. Loss of protective sensations. So when we take this instrument and apply firm pressure, right, it can only exert pressure equivalent to 10 grams. उसके आगे ये प्रेशर नहीं डाल सकता है. उसके आगे आप कंप्रेस करने की कोशिश करोगे, it will go on buckling like a C, but it will only transfer pressure of 10 grams. That is why it is called a 10 gram monofilament. Now if you can feel this much pressure, then even if you have neuropathies, you're kind of protected from micro traumas and you're safe. You don't need to do anything extra other than treating the underlying cause and giving you symptomatic treatment. But if you don't feel this, मतलब 10 ग्राम का प्रेशर आप फील नहीं कर रहे हो, so that means you are at risk for micro traumas which can eventually cascade into resulting in amputations. तो जिसको भी ये टेस्ट में we identify that they are not able to feel it, that means जो sensation की protection threshold है उससे भी ज़्यादा sensation loss हुआ है, they've lost the protective sensation. So for them we need to do special care, special footwear चाहिए, daily foot examination. हर दिन पेशेंट को हम बताते हैं कि सुबह शाम आपके पैर को बैठ के कुछ मिनट के लिए एग्जामिन करो, कहीं पे कोई ट्रॉमा है या नहीं, कुछ दिख रहा है तो इमीडिएटली डॉक्टर के पास रिपोर्ट करो, सो दैट वी कैन आइडेंटिफाई एंड ट्रीट इट. एंड स्पेशलाइज्ड फुटवेयर जरूरी पड़ेगा, एंड स्पेशलिस्ट कॉल्ड पोडियाट्रिस्ट, उनके पास रेगुलरली फॉलोअप के लिए जाना पड़ेगा. So this helps us identify those who are at risk of major foot issues resulting in amputations. So the important use of it is used for identification of loss of protective sensations and not for sensation है या नहीं उसके लिए हम इसको यूज नहीं कर रहे हैं. पेशेंट खुद बताए कि मुझे सेंसेशन नहीं है, हम ये देखना चाह रहे हैं कि जो लॉस ऑफ सेंसेशन है वो प्रोटेक्शन थ्रेशोल्ड से भी ज्यादा लॉस हुआ है या अभी ठीक ठाक है, कि खुद ब खुद अपने फुट को पेशेंट प्रोटेक्ट कर पाएगा या नहीं, राइट? So its objective is to detect loss of protective sensations. Okay. Now the last bit. Once we have a case of peripheral nerve disorder, how do we manage them? First principle is simple: treat the underlying cause. Right? Diabetes है, control करो. नहीं करोगे तो ये न्यूरोपैथी और बढ़ता जाएगा. Right? अभी like usually described as glove and stocking distribution. Hand में और feet में loss of sensation है. Hand के feet के muscles weak हैं. Time बढ़ते जाएगा. If you don't control, then your forearm muscles, leg muscles will start going weak, so it will progress. So treating underlying cause is important. Second, protective care is very very important once you have an established case of neuropathy, particularly with loss of protective sensations. इसलिए हम वो monofilament test कर रहे हैं, right? Semes Weinstein monofilament test. अब protective care में होता क्या है? You might have to create specialized footwear. Like nowadays we can like ask the patient to go to a podiatrist. Podiatry is a branch of medicine concerned with foot care. इसकी जरूरत इसीलिए पड़ रहा है कि डायबिटीज इतना आगे बढ़ गया है, and so many patients with diabetic neuropathies eventually getting amputated. So we have come out with a specialized branch called podiatry which cares for the foot. So we should generally refer the patient to podiatrist. Now they have myriad tests. So what they will do is they will ask you, They will do what all areas you have lost the protective sensations. Then they will also identify the pressure points, and they will design specialized footwear to properly distribute the pressure points. But because otherwise क्या होता है, patient doesn't have any sensation, so foot के कुछ areas में there will be excess pressure, and they start developing the pressure ulcers. From there again diabetic foot and amputation. So they can all be prevented. And then they have specialized orthotic braces and all, which can be helpful in protecting their foot. And third, जिनको underlying cause treat नहीं किया जा सकता है, like hereditary sensory motor neuropathies, or like in such patients, what can we do? We have to only thing we can offer is rehabilitation. Like we saw these deformities, right? Like pes cavus deformities. या तो ये surgically correct किया जा सकता है, or with orthotic braces it can be handled. So we have to think of rehabilitation. So this is how we basically manage a case of peripheral neuropathies. Okay. So that's it for today, guys. In the next session, we are talking about seizures. Small homework would make it easier for you. Just solve some MCQs from the seizures. I'm not asking you about the epilepsy or pharmacotherapy of seizures. The focus is on understanding what is seizure, what is epilepsy, what is the difference between seizure and epilepsy, and what is difference between convulsive and non-convulsive seizures, and how to interpret the EEG. Just solve few questions and then come back and we will address them. Yes, Nilanjana, hypothyroidism also causes neuropathy, because in hypothyroidism, the metabolism of the neurons is also impaired. So that can cause neuropathy. Okay, so I will not get into the detailed discussion of the peripheral neuropathy management. We are going to do the diabetes later. So in diabetes, we will discuss even the subtypes of peripheral neuropathies. The diabetic neuropathy in itself is a 10-mark question for an undergraduate student. What we need to cover in the diabetic neuropathy is we need to understand different distributions. The glove and stocking distribution is one type, but there are various other types of neuropathies that can happen in diabetes. And apart from that, we have to also understand small fiber neuropathy, large fiber neuropathy that we see in diabetes. We will be doing a separate session. I'll address all of it there. Okay, so see you soon, guys. Till then, have a good time. Good night.